when you consider adding medicines for individuals with type 2 diabetes, the most important thing is to try to take into account all of the individual's other clinical characteristics. So you want to know, do they have a history of GI problems? If they do, if they've had diarrhea, if they have a lot of problems with heartburn or nausea, then they might not be good candidates for the GLP-1 receptor agonists, for which these tend to be side effects. Do they have a history of urinary infections, or in men, prostatism, in women, vaginal yeast infections? In such an individual, the use of an SGLT2 inhibitor might have the undesirable side effects of worsening these problems. Do they have a history of congestive heart failure, or do they have peripheral edema, or have they had osteoporotic fractures, or do they have any evidence of macular edema, a form of diabetic retinopathy? Are they individuals for whom we're worried about weight gain? Those all might be considerations that would lead one to be less likely to use a thiazolidinedione. Do they have a history of hypoglycemia? If they've had hypoglycemia problems, then giving a sulfonylurea or insulin would be undesirable, because these agents are intrinsically associated with hypoglycemia, and both the sulfonylureas and insulin tend to be associated with weight gain. Now, in addition, we want to think about ways in which the drugs might benefit patients. And so we have the recently released results of the IRIS study with pioglitazone, which showed that individuals who don't have diabetes but have insulin resistance, who are given pioglitazone with a past history of stroke, have a reduction in the possibility of subsequent heart attack and stroke. That certainly is a very important consideration, and it supports the findings of the PROACTIVE trial done a number of years ago, in which individuals with a history of stroke who did have diabetes had a reduction in subsequent stroke when treated with this agent. If there are people who have heart failure, then the results of the EMPA-REG trial are of great interest, because in the EMPA-REG cardiovascular outcome trial, individuals who were at high risk and were randomized to empagliflozin actually had a reduction in the likelihood of cardiovascular mortality, and as a secondary endpoint, a reduction in need for hospitalization for heart failure. So, thinking of heart failure as a very key part of the diabetes heart disease spectrum, one could say the use of this agent, and perhaps other SGLT2 inhibitors, might be expected to be highly beneficial in reducing outcome. We have recently learned top-line results of the LEADER trial with liraglutide, showing that, again, in a high cardiovascular risk population, the use of liraglutide was associated with a reduction in myocardial infarction, in stroke, and in cardiovascular mortality. So this suggests then that individuals receiving this agent might really benefit. And to some extent, we don't know exactly what the mechanisms are. In other ways, we do have ideas. So there's somewhat of a diuretic, a natriuretic effect of the SGLT2 inhibitors. That might be of benefit in heart failure. The insulin sensitization of pioglitazone appears to have benefit in decreasing the atherosclerotic process. And the overall potent glucose lowering without causing hypoglycemia seen with liraglutide could well be beneficial in individuals at high cardiovascular risk, particularly, one might speculate, if they are able to avoid using sulfonylureas, which we think may be associated with intrinsic cardiovascular toxicity.